Hi, I'm Dominique Penning and I'm the course director for the introduction of diagnostic ultrasonography. And this narrated lecture online is on ultrasonography of the gastrointestinal tract. The main objective of this course are to know the normal appearance of the main segment of the gastrointestinal tract in dogs and cats, and also to know how to scan the different portion of the gastrointestinal tract. These first two goals have already been reinforced by your review of all the narrated video clips on the normal abdomen in dogs, and I encourage you to review these video clips as often as possible to best prepare yourself, not only to the wet lab, but also to build reference images of normal organs. The other objectives are to know the common imaging artifacts that you will encounter while scanning the gastrointestinal tract, and also to be familiar with the ultrasonographic appearance of disorders such as intussusception, mechanical ileus, foreign body, inflammatory diseases, and also the most common gastrointestinal tumors. And finally, you will get familiar with the basic interventional procedure that can be performed on the GI tract. Scanning and navigating through the gastrointestinal tract is mostly covered in the video clips on the normal abdomen in the dog. And you can also find useful resources and additional information in the Atlas of Small Animal Ultrasonography that is available at the library. The gastrointestinal tract may contain a wide variety of ingesta. On the picture on the top, we see actually organized rounded structure within the lumen of the stomach that represent kibbles. We can also see fluid that can appear either anechoic or echogenic, and in general, fluid contents will facilitate the evaluation of the gastrointestinal wall. On the other hand, the presence of gas that may appear as reverberation and comet tail artifact or shadowing will usually limit the evaluation of the far wall of the gastrointestinal tract. Wall layering is an important part of the GI wall evaluation. Once the lumen is clearly identified as a hyperechoic interface, often with tiny gas bubble, we can see on each side of that lumen a discrete, thick layer, nearly anechoic, that is the mucosa. The mucosa is then bordered by a discrete hyperechoic layer that represents the submucosa. The muscularis layer is also nearly anechoic, but much thinner than the mucosa. And finally, we have a hyperechoic outer layer that represents the combination of both the subserosa and serosa. As far as layer distribution, as we just saw, the mucosa is often in the small intestine by far the thickest layer, but it's not the case for the stomach and the colon, where both the mucosa and the muscular layer appear relatively similar in thickness. Most disorders tend to affect the size of an organ or structure, and therefore reference values will be part of what we will be looking for while we evaluate the GI tract. And to navigate through this table made of recently reported mean thickness measurements, I will start by the stomach, And we can see there is a wide variability of wall thickness from 2 to 5 millimeter, as the stomach is actually a very large hollow organ that will greatly change in size from being collapsed to distended with variable amount of fluid, gas, or ingesta. And this is true for both dogs and cats. When comparing duodenum with jejunum in dogs, it is noticeable that the duodenal wall is thicker than the jejunal wall. And you can also observe that the thickness of the small intestine increases with the size of the dog. However, in cats, the duodenal wall has similar thickness than the jejunal wall. And in cats, we can also notice that the thicker small intestinal segment is actually the ileum, unlike in dogs where it was the duodenum. The colon in both dogs and cats has a similarly thin wall, and as mentioned before, the mucosa and muscularis layer have similar thickness. Early detection of obstructive foreign material can significantly affect the outcome for the animal. Survey abdominal radiographs are useful in identifying radiopaque foreign material, and they commonly are taken to rule out mechanical obstruction in vomiting pets. In this 5-year-old vomiting dog, the foreign material is quite obvious, and we can even predict what he is. However, in many instances, the foreign material cannot be detected on radiographs, and intestinal dilation may not be obvious. In experienced hands, ultrasonography is useful in diagnosing mechanical obstruction and in detecting foreign body. Let's review the main feature encounter with them. The size, shape, and composition of the foreign material affect the echogenicity and ecotexture of the foreign body. At times, the foreign body may be uniformly echogenic, as seen in this fluid-filled stomach of a dog presented for chronic vomiting, and in that case, the spongy ball was easily identified. However, in most instances, the foreign body will appear as an irregular, hyperechoic, bright interface associated with strong, clean, uniformly black shadowing. This can be seen easily even in this collapsed stomach. Inquiring about recent meal contents is very important, as some ingesta could be mistaken for foreign material. In this last example, the foreign body has a long linear interface, and there is also fluid accumulation oral to the foreign material. The fluid distended loop supports an obstruction, and in this case, surgery is recommended to release the obstruction. Let's review the video of the last foreign body we discussed. There is a large amount of fluid and gas with reverberation in the fundus of this cat presented for acute vomiting. The antrum is collapsed, and then as we follow the duodenum, we observe that is fluid and gas distended. It reaches up to 1 centimeter in overall diameter. There is very little peristaltic activity. And then we finally reach that curvy, linear, bright interface associated with strong, clean shadowing, and right after the bowel segment returns to a normal diameter. The shape of this foreign body is actually suggestive of a hairball, and in this case it's an obstructive foreign body as we had fluid accumulation or add to it. This was confirmed at surgery. An elongated foreign body is not necessarily a linear foreign body that induces plication. As we see in this drawing, in linear foreign body, we usually have a component that is somewhere stuck within the GI tract. In this example, it is anchored in the antrum. And then the long linear part of the foreign body extends into the intestinal tract, but cannot move through it. The affected loop or loops are then plicated, and they may contain variable amount of gas or fluid. The plication make the bowel look like hair scrunchies. We see bowel segment being mildly thickened and hyperechoic linear structure associated with shadowing seen in the lumen. If you observe the wall of that intestinal segment is actually somewhat thickened compared to some other loops, and also at places the layering appears diminished. This is most likely the result of the localized inflammation due to the friction of the foreign body. It is then difficult to follow the foreign material, as we will follow it through the GI tract, keep comparing the affected bowel segment with the adjacent normal bowel segments. Here's the foreign material. It's a large amount of it, surrounded by fluid accumulation. Places the fat around the affected segment appear slightly increased in echogenicity. And then finally we get into that plication effect around the linear foreign body. The bowel are folding on themselves. This is what intestinal plication will look like. Deep fold around a linear foreign body. But plication secondary to a linear foreign body should not be confused with corrugation. With plication, the scrunchy-like intestinal folds are actually folding on themselves, while corrugation appears as more of a symmetrical undulation, preserving the straight course of the serosa. Corrugation is not a specific feature and can be encountered in several conditions that often are associated with regional inflammation, such as pancreatitis, peritonitis, enteritis, but also can be seen in ischemic bowel segment or neoplasia. Therefore, this feature does not automatically indicate a mechanical compromise requiring surgery, unlike plication. Intussusception consists of an intestinal segment sliding or invaginating into another section of intestine, just like a collapsing telescope. The outer segment is called the Intussusceptions, and the invaginated segment is called the Intussusceptum. In ultrasound, the intussusception is often described as the too many layers sign, as the superimposition of the closely apposed intestinal walls can be confusing. Then on this drawing, we also can see in this midjejunal invagination that the intussusceptum drags along some mesenteric fat, and this results in a bright crescent of intussuscepted fat, as we can see on transverse images. The appearance of this fat will vary depending on the section obtained through the site. The intussusception causes a mechanical obstruction, and therefore we will see usually fluid or gas distension or rad to the intussusception site, as seen on this ultrasound image. The transverse views usually are easier to interpret, as they display the inner intestinal segment surrounded by the crescent of hyperechoic fat. And then we also can see the thickened edematous outer intestinal segment, and usually poor motility is observed at the invagination site. It is important to fully evaluate the intussusception to rule out the presence of foreign material, or in older animals, the presence of a mass. In these video clips, we will see an intussusception, and starting with this snapshot of a transverse view of the intussusception, we see the intussusceptions that is showing a thickened wall, poorly demarcated layering due to the edema of the wall, and then we can see also the squeezed intussusceptum that has preserved normal layers, and the asymmetrically located intussuscepted mesenteric fat. In real-time evaluation of the intussusception in this dog, we see enlarged jejunal lymph node with some cystic-like component. And now we are approaching the intussusception with the invaginated by fat, and we actually see part of the jejunal lymph node inside the intussusception. We maneuver along the intussusception, again 2 jejunal lymph nodes, the inner segment, and now we are out of the intussusception. We see part of the bladder, indicating that the intussusception is actually caudally located. Longitudinal view of the intussusception, the inner bowel segment, the invaginated lymph nodes, and the outer bowel segment. A little more difficult to evaluate on longitudinal view, as we see on these transverse images. Is much more obvious to see the outer bowel segment, the inner bowel segment, and in this case, the invaginated jejunal lymph node. Inflammatory diseases cannot always be detected on ultrasound, but when they are, they usually will have some degree of wall thickening, usually mild to moderate. They will also display alter layering, and we'll discuss that in a minute. At times, regional lymph node will be mildly enlarged as the result of reactive lymphadenopathy, and the extent of the changes can be either localized to one long bowel segment or affect several or most of the GI tract. Possible motility changes can be detected, although it may be subjectively assessed on ultrasound, and as we suspect inflammatory disease, screening for ulceration is always recommended. Alter layering, in contrast with the normal bowel layers that we described earlier in the course, will appear as a change in relative thickness of one of the layers. It can be a thickened mucosa or thickened muscular layer, or even thickened submucosa, or it may be a change in the echogenicity of the layers. As we remember, the mucosa and muscularis layers should be nearly anechoic, but at times we will see changes affecting the mucosa to the point that is diffusely hyperechoic. Or we may just have decreased wall layer demarcation. All of that qualify for the alter layering label. On this real-time evaluation, we see a dog that has a scan amount of effusion in the abdomen and then bowel segment that were mildly thickened. And you see the speckly appearance of the mucosa, giving an overall increase in echogenicity. The wall layer also led to an increased thickness of the intestinal wall, leading to up to 6 mm, which is too thick in this small-sized dog. In addition, the fat near the bowel segment is slightly hyperechoic. That may be the result of that free fluid in the abdomen. Now let's see some of the specific alteration of the wall layers, and the first one is muscular hypertrophy. Then in this case, it will be important to locate the lumen of the bowel, and from the lumen see the mucosa, submucosa, and muscular layer. And in this case, it's quite obvious that the muscular layer is much thicker than the corresponding mucosa, and can be also proven in histopathology slide. This feature or this finding is quite easy to pick up. However, it's a non-specific feature that can be seen with enteritis or as a response to a mechanical obstruction due to a foreign body or neoplasia. Here is an example in real time in this cat. You can see on the left the image, the insert of the animal as we are going to scan it. And you see several bowel segments. This change in the bowel is diffuse in this cat. And as we go along, we have first to determine where is the lumen. And from the lumen, we then can see the mucosa, which is hyperechoic, submucosa, and muscular layer. As you see in all these bowel segments, the muscular layer is significantly thicker than the adjacent mucosa, which in this case is also hyperechoic. This is the bladder. Other bowel segments that can be seen and are corresponding to a type of alter layering will be striation, and the striation will be this hyperechoic line that are displayed within the mucosa and are perpendicular to the long axis of the lumen. This striation, this hyperechoic striation, are actually dilated lacteols, and that has been documented in the literature. And this feature of hyperechoic striation is frequently associated with some degree of mucosal inflammation and protein losing enteropathy. But you can have also a mixture or combination of all these different type of wall alteration. And here we see an example of speckles, hyperechoic foci within the mucosa in this mildly thickened bowel segment. In this case, after endoscopic biopsy was diagnosed as a case of inflammatory bowel disease, we are really not sure what the speckles represent, if they may be actually some degree of lacteal dilation. However, this feature can also be seen in dog during digestion. Then it's not necessarily a signature of pathological changes. As we mentioned, the striation may have variable amount of diameter and maybe at times not that obvious, but in this example diagnosed as lymphangiectasia, we see that almost circular appearance of this dilation. more subtle changes may be like what we see here, this very thin linear band crossing the mucosa. Histopathologically, in some instances, this band is actually shown to represent mucosal fibrosis. In this specific cat, the diagnosis was eosinophilic enteritis. All these features are not pathognomonic of any specific disorder, but can be seen in combination of several other changes that affect the bowel and usually will indicate some degree of inflammation. Within the scope of this course, we will describe only the most commonly encountered neoplasia and describe their depend on the histopathology of the lesion, and regionally the motility will be also affected. Then important to recognize loss of layering as the complete absence of any wall layer recognition. The first type of neoplasia to evaluate will be the round cell tumors, most commonly encounter one being lymphoma. It's also characterized by marked thickening of the wall, which can affect long bowel segment or several bowel segments. And that loss of layering usually results in what appear to be a polyechogenic wall. The important feature in detecting this lesion is often to identify the lumen. We can see here a lumen that has some echogenic fluid versus a lumen here that actually contains some gas. Regional lymphadenopathy is a very common feature in lymphoma. In rare occasion, the lesion may create obstruction, but this is really uncommon in round cell neoplasia. In few instances, we may also see actually layer wall, and in this case, it may be difficult to distinguish a lymphoma from an inflammatory bowel condition. In this video clip of this cat, we are going to evaluate a jejunal segment that show marked thickening of the wall, about 6 to 8 millimeter. This represents gas in the lumen. Notice also the irregularity of the wall, especially at this location where there is actually dissection within the wall. This is a signature of ulceration. In addition, there is bright fat around the lesion with impression of, at times, a small amount of fluid dissecting the fat. Color flow Doppler show that there is moderate vascularization of this lesion. Notice also, while we are moving to the cranial portion of the abdomen, that we have a very large polyechogenic structure, mass, seen in the mid-abdomen, and that lesion is lying on the side of long jejunal vessel and most likely represent markedly enlarged jejunal lymph nodes. Then the combination of these two features of the intestinal mass and the massive jejunal lymphadenopathy is strongly suggestive of round cell neoplasia, and a fine needle aspirate would be the next logical step to take in this cat. Unlike lymphoma, intestinal carcinoma usually appear as a single focal thickening of a bowel segment with complete loss of layering. This lesion usually produce a very significant narrowing of the lumen at that location, and for that reason radiographically have been called apple core lesions. Then we are going to see a case of intestinal carcinoma. And in this example, we see a lesion with loss of layering that is right on the margin of a dilated bowel segment that is mostly gas-filled on the left. The lesion, here's the gas-filled dilated segment, and now we go to this lesion, which is primarily involving circumferentially a short segment of this jejunum. We see the lumen at some point being really squeezed within that segment. Here is the lumen. Around that lumen, we have polyechogenic thickening. As you have seen, this thickening appears to be quite focal within the lesion. There's also impression of bright fat near the affected bowel segment. This segment of bowel at that location returned to normal. As we try to go aborally, we really cannot follow that lesion because there is a fair amount of gas on each side of the lesion. Then we take measurements, and the overall length of the lesion is less than 2 centimeters, and the overall thickness is about 1.2 centimeters. Then classically, we would try to follow the bowel segment on each side. This is the aboral side, and we see that is collapsed. And the oral or orad side of the lesion is very difficult to evaluate because it's primarily gas distended. At times, you may also notice that there is thickening of the muscular layer. This is most likely a result because this lesion is obstructive. We see very well here the muscular thickening. The third category of GI neoplasia that we will discuss are eccentric tumors, as seen in smooth muscle tumor and in gastrointestinal stromal tumors. This lesion cannot be distinguished from one to the other, but they have one feature in common, is that they are eccentric mass. They often are quite large at the time of the diagnosis and tend to have cavitary component, especially if they are more than 3 centimeters in diameter. Unlike the previous tumor we discussed, these tumors don't have tendency to have regional lymphadenopathy, and they are also rarely obstructive. This is an image of a mass, a very large mass, with an eccentric cavitation within the lesion. And the origin of this lesion could be attached to the GI tract only by the presence of a small amount of gas within the lumen of the mass. Example of gastric leiomyoma, we have the lumen being here, and the near field wall is actually within normal limits, where the far field is presented as a mass, inhomogeneous mass with impression of potentially necrotic zones. Seen in real-time ultrasound, this lesion may be very challenging to diagnose. It's easy to find the lesion, which is usually a very large polyechogenic mass surrounded by hyperechoic attenuating fat, but it's often difficult and challenging to find the origin of these lesions. And in this case, after quite a bit of time exploring the lesion, we can see in the periphery of the mass a structure that we will actually follow, because it seems that we have sometimes dots of gas in it. And now we recognize that this bowel segment is actually intestinal and seems to be the origin of this mass. Then based on this discovery, we have now more evidence that this mass is actually intestinal in origin, and the dog was sent to surgery. The surgical specimen shows us what we just saw on ultrasound. Here is the intestinal segment. We see that the mucosa is mostly intact. We can even see also the fold of the lesion as is distorted by this large mass, which is primarily eccentric. The histopathological diagnosis of this lesion was gastrointestinal stromal tumor, although immunohistochemistry tests were recommended to confirm this suspicion. All these lesions that we describe, especially for tumors, are very promising. However, they are overlapping features between inflammatory and neoplastic groups. For example, we may encounter inflammatory changes in a bowel with wall thickening exceeding 1 centimeter or even associated with loss of layering. In these instances, often the changes are secondary to severe transmural inflammation, usually combined with some degree of edema, fibrosis, hemorrhage, or even necrosis of the wall, and they may be secondary to processes such as bowel perforation. Inversely, intestinal tumor may sometimes have a subtle wall thickening and may also at times not have full loss of layering. We have seen example of that in actually lymphoma earlier in the lecture. Then it means that we have to be really careful as we are trying to label the diseases that we encounter on ultrasound, and it's therefore very important to recommend ultrasound guided procedures such as fine needle aspiration or core biopsy. Fine needle aspiration commonly will be performed using a 22 gauge fine needle, where the core biopsy will usually use an automated gun and take sample of about using an 18 gauge needle. The important safety measure to take is to visualize the lumen to make sure that the needle can be safely advanced and not penetrate the lumen to avoid potential leakage within the abdomen. We'll see an example of this procedure, a fine needle aspirate in a cat. Notice the position of the probe and the needle in the left hand. And as we go, we see that we first color flow to make sure we don't see any near field vessel that could compromise the procedure. We see now the motion of the needle, and during real-time evaluation, we actually can see the motion in and out of the needle within the thickened wall of this bowel segment. And this is happening far away from the lumen, which means that this procedure is safe. Afterwards, we still control using color flow Doppler to assess the potential bleeding, and we see only a faint trace, and this is within normal limits for the procedure. This concludes this lecture on gastrointestinal ultrasonography. If you have any question, feel free to bring them along during the lecture time allocated to the topic or during our clinical case review. Thank you.